Welcome to this ASN Kidney 360 podcast. I am Christa Krom, member of the Center for Patient-Centered Outcome Research at the Charité University Medicine Berlin, Germany. And I'm also Director of Person-Centered Outcomes Research in the Global Medical Office of Fresenius Medical Care. Today, I'll be discussing our study, published in Kidney 360, titled Psychosocial Determinants for Self-Reported Health Status in Hemodialysis Patients, a cohort analysis of the CONVINCE randomized trial. So what were the aims and methods of this study? We investigated whether the two psychosocial determinants, self-efficacy and social support, are associated with health-related quality of life in hemodialysis and hemodiafiltration patients that were enrolled in the CONVINCE trial. This trial had investigated the superiority of hemodiafiltration over conventional guideline-based hemodialysis in 1,360 patients in 8 European countries. We used baseline data for this analysis from that cohort involved in the CONVINCE randomized control trial. The measures included were age, gender, relationship status, the number of children, housing, education, employment, comorbidities, dialysis schedules, the first time somebody's got on dialysis, residual kidney function, general self-efficacy, and social support scores that were measured directly in patient questionnaires. So health-related quality of life was measured using PROMIS short forms that were originally developed in the US at Northwestern University, and they were made available to patients both electronically and on paper in case patients prefer to fill in these questionnaires on paper, or the clinics were for some reason not able to provide the electronic form on tablet computers. Associations were analyzed using hierarchical regression. We first put in demographic variables, and then medical variables, and finally psychosocial determinants as consecutive blocks to analyze these steps in our analysis. So what are the key findings of our study? We had 1,264 respondents. Almost all patients had filled in the baseline assessment forms. This is a very high return rate out of the 1,360 patients that had originally enrolled in the trial. The patients were between 20 and 92 years old with an average age of 62 years. 66% were male. Self-efficacy was a significant predictor for all health-related quality of life domains, with the strongest effect sizes for depression, followed by anxiety, social participation, cognitive function. And finally, there were also significant relationships with fatigue, physical function, sleep disturbance, pain interference, and finally pain intensity, intradialytic symptoms, and intradialytic symptoms. Social support was only a significant predictor for cognition, sleep disturbance, and intradialytic symptoms. Across the 11 dependent variables that we analyzed, demographic variables significantly explained variance in all domains. For example, age had a significant effect on physical function, social participation, pain interference, and pain intensity. Gender had a significant effect on all health domains apart from cognition and sleep. Education had a significant effect on cognition, anxiety, and intradialytic symptoms. The vocational status of participants had a significant effect on all health domains, barring physical function. The addition of medical variables in the second step significantly improved the models for all dependent variables. The significant determinants were comorbidity and/or residual micturition for most variables. The inclusion of psychosocial determinants in the third step finally led to the significant increase in variance explained in most dependent variables, with self-efficacy being a significant determinant for all variables. We there found standard betas ranging from minus 0.14 to plus 0.36. For social support, we found beta values ranging from minus 0.11 to plus 0.21, but only for the set variables of cognition, intradialytic symptoms, and sleep disturbance. The largest overall effect size with a value of f-square of 0.37 was found for the third model with cognition as a dependent variable, followed by physical function with a value of 0.33, and depression with a value of F square of 0.25. What are the limitations of our study? Let me first mention, our study had unique strengths. Its comprehensive approach to investigating the relation between self-efficacy, social support, and health-related quality of life among a large and diverse group of dialysis patients has never been investigated before. It leverages data from the CONVINCE trial, enhancing the generalizability of its findings beyond samples that only comprise data from a small number of dialysis centers, or in a single country, or just in university clinics, or in contrary, only in commercial centers. The utilization of validated instruments for assessing self-efficacy, social support, and health-related quality of life outcomes ensures the reliability and validity of the study measures. Furthermore, the adoption of hierarchical regression modeling allowed us to rigorously examine the independent contributions of self-efficacy, social support to health-related quality of life variance, while controlling for relevant sociodemographic and medical factors. However, there are also clear limitations. To limit respondent burden, we did not collect other psychosocial constructs besides self-efficacy and social support within the setting of this trial. For example, we excluded worry, helplessness, and religiosity, all of which are really important factors for quality of life. Worry and helplessness are frequently associated with elevated stress levels and diminished health outcomes. In contrast, religiosity has been shown to offer emotional support and coping mechanisms that enhance mental health and overall well-being for many patients. Further research may incorporate these factors, and I explicitly hope that it will be taken up in the future. The selection of patients able to achieve higher convection volumes for hemodiafiltration may have also been an issue limiting external validity of this study. The trial was designed to statistically be powered for the primary outcome of mortality, and that limits the strengths of associations of the secondary patient-reported outcomes. However, the statistical tests have shown very normal distributions, and the hierarchical regression approach consistently showed significant effects across the blocks of variables entered into the analysis, and that all speaks against this risk. Finally, the CONVINCE study had a European population. Despite the inclusion of various countries across the continent, from the north, south, and east, this may have an impact on the applicability to other regions with different socioeconomic and health disparities, such as the United States. So how can the results of this study be used to change clinical practice or service provision? Clinicians should prioritize psychosocial assessments alongside biomedical evaluations that are currently the standard of care. The identification of specific health-related quality of life domains, most strongly influenced by psychosocial determinants, can guide targeted interventions tailored to individual patient needs. Ensuring appropriate healthcare resources at a clinic level, such as the psychologists working there, social workers, and supportive care nurses, to improve self-efficacy and social support, can enable this type of individualized patient care that we strive for. This approach is relevant to improving patient outcomes, particularly in chronic conditions such as end-stage kidney disease, where psychological and social factors exert an influence on health-related quality of life. The use of patient-reported outcome measures enables clinicians to identify specific areas where patients may be experiencing difficulties and to adapt to interventions accordingly. For example, patients with low self-efficacy benefit from targeted self-management programs or cognitive behavioral interventions designed to enhance their confidence in managing their health. Evidence from previous studies indicates that self-efficacy interventions can lead to significant improvements in clinical outcomes, such as phosphate control and fluid management, and can improve adherence. There are also ongoing studies employing technology-assisted psychosocial interventions based on cognitive behavioral therapy to improve patient-reported outcomes. Higher self-efficacy and stronger social support have demonstrated to be generally associated with enhanced health outcomes, including an improvement in physical functioning, emotional well-being, and social participation. Furthermore, structured social support interventions, including family therapy and community support groups, can equip patients with the necessary resources and encouragement to adhere to their treatment plans and maintain a positive outlook. We, as the investigators of the study, want to emphasize the need for continuous psychosocial assistance throughout the course of treatment. Regular follow-ups with patient-reported outcome measures can help monitor changes in patient self-efficacy and social support levels, allowing for timely adjustments to care plans. This proactive approach offers patients continuous support, reducing the risk of treatment non-adherence and improving long-term health outcomes. We suggest that future research incorporates psychosocial determinants in a comprehensive health-related quality of life assessment, as is done in some studies that are currently underway. Given the early state of research, it is important to include longitudinal trajectories of health-related quality of life outcomes to understand the underlying mechanisms of the observed associations between self-efficacy, social support, and health-related quality of life. More emphasis should be given to exploring the directionality of these effects and to understand pre-existing levels of health to improve patient outcomes in the future. In conclusion, reducing inequality in healthcare is not a separate activity from delivering optimal treatment in the dialysis clinic. The effects can add to each other and can create significantly better health-related quality of life and better survival for patients at the same time. We should continue reporting outcomes using the standard outcomes in nephrology or SONG criteria and work towards delivering adequate dialysis to all patients, no matter where. Thank you for joining us for this Kidney 360 podcast.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.